Hello everyone, I am Dr. Prashant, and in this presentation we will talk about the causes, diagnosis and management of ascites. Ascites is defined as collection of fluid within the peritoneal space and comes from the word ascos, which means a bag. The pathogenesis of ascites is related to the anatomy of the liver and its surrounding structures. This is the splenic vein, this is the superior mesenteric vein, and formed by the confluence of these two structures is the portal vein. In a patient with portal hypertension, there is obstruction to the flow of the blood in this direction and in this direction, resulting in increased portal pressure, resulting in portal hypertension. When there is portal hypertension, there is increased nitric oxide in the splanchnic circulation. This results in vasodilatation of the vasculature in the body. The kidney interprets this vasodilatation as hypovolemia and activates the renin-angiotensin system along with increased ADH and starts to retain sodium and water. This retention of sodium and water is key to the pathogenesis of ascites, the human body. To summarize, portal hypertension causes increased nitric oxide, which causes vasodilatation. This results in renal sodium retention, increased sympathetic activity, increased renin and aldosterone, as well as overfill of the intravascular volume. Both these factors result in ascites formation. The causes of ascites may be due to cirrhosis of the liver, and this is the case in 85% of the cases. Other causes include portal hypertension related disorders, cardiac disease, and peritoneal carcinomatosis. We will discuss the causes of ascites in detail later in this presentation. Let's discuss the history in a case of ascites. In a patient with cirrhosis, excessive alcohol use, hepatitis C, and non-alcoholic steatohepatitis, or NASH, are the most common causes of cirrhosis. For the history of NASH, lifetime maximum body weight must be inquired for. In a patient with long-standing stable cirrhosis, sudden decompensation could mean hepatocellular carcinoma. Malignancy can also cause ascites, and this can occur in conditions like breast cancer, lung cancer, colon cancer, and pancreatic cancer. The history of injection drug use in a case of ascites is important, along with history of tattooing for hepatitis B and C. We must also take the history of blood transfusions prior to 1992 because screening of blood was not a universal precaution before 1992. Other aspects of history include ear piercings, acupuncture, and country of origin. Furthermore, a patient who presents with fever and abdominal pain may be having abdominal tuberculosis. A patient who has heart failure may have cardiac ascites, and a patient who has anasarca may have nephrotic syndrome related ascites. Physical examination is of vital importance in a patient with ascites. A patient may have flank dullness, in which the percuss dullness is higher than the anticipated height with the patient in supine position. There may also be shifting dullness, for which 1500 ml of fluid must be present. The patient may have peripheral stigmata of chronic liver disease such as palmar erythema, large pulsatile spider telangiectasias, and large abdominal collateral veins. In patients who have central dullness, we must think of an ovarian mass, thickening of the omentum, or paniculus thickening. Other aspects of examination in a case of ascites include Sister Mary Joseph nodule, which suggests peritoneal carcinomatosis. A prominent Y descent of the JVP can suggest constrictive pericarditis, and this is a curable cause of ascites. Raised JVP may also be present in alcoholic cardiomyopathy, and periorbital edema may suggest nephrotic syndrome as a cause of ascites. Ascitic fluid analysis forms an important part of evaluation and management of patients with ascites. Gross appearance of the ascitic fluid is of vital importance. In most cases, ascitic fluid is straw-colored. However, if the ascitic fluid is watery, this means that the protein content is very low. If the ascitic fluid is cloudy, then this means that the cell content is more than 5,000. If the cell count is more than 50,000, then the ascitic fluid may be like mayonnaise. If the ascitic fluid is pink, then that means that the RBCs are more than 10,000 per microliter. And to correct for traumatic taps, we must subtract one polymorphonuclear neutrophil for every 250 RBCs. If the ascitic fluid is tea colored, it could mean a melanoma. If the ascitic fluid is black in color, it could also mean a melanoma. The cells in ascitic fluid are of vital importance. If the white blood cell count is more than 500 or the PMNs or polymorphonuclear neutrophils are more than 250, then we must culture the ascitic fluid. If there is a single organism in the culture and the total protein is less than 1 with a glucose of more than 50 and a LDH of less than 225 international units per ml, this means that the patient has spontaneous bacterial peritonitis. If the culture of ascitic fluid shows polymicrobial culture and the total protein is more with a low glucose and a raised LDH, this means the patient has surgical peritonitis. We can discuss the spectrum of infections in the ascitic fluid here. In a patient who has a positive ascitic fluid culture with a PMN count of more than 250 cells per millimeter cube, such a patient is said to have spontaneous bacterial peritonitis. If the patient has no growth on culture but a cell count of more than 250 per millimeter cube, he is said to have culture negative neutrocytic ascites or CNNA. If the patient has a positive culture for a single organism but cells are less than 250, such an ascites is called monomicrobial non-neutrocytic Bacter ascites. In a patient who has a polymicrobial growth along with cell count more than 250 and an apparent surgical cause, such a patient is most likely having secondary bacterial peritonitis. Finally, in a patient with cells less than 250 with a polymicrobial growth, such a patient is said to have polymicrobial Bacter ascites. Let's discuss the importance of protein in the ascitic fluid. One of the key concepts in ascites is the serum albumin ascitic gradient, or SAAG, also called SAG. For the calculation of SAG, we must take the serum albumin, let us take an example 3.5 grams per deciliter, and we must subtract from it the ascitic fluid albumin. Let us take an example of 1.2 grams per deciliter. In this case, the serum albumin ascitic gradient is 2.3 grams per deciliter. The utility of serum albumin ascitic gradient or SAG is that any patient who has a serum albumin ascitic gradient of more than 1.1 grams per deciliter is classified as having high SAG ascites, a term which is synonymous with portal hypertension. On the other hand, patients who have a SAG of less than 1.1 grams per deciliter are said to have low SAG. The serum albumin ascitic gradient is a key concept in the understanding, evaluation, and management of patients with ascites. As already discussed, high SAG is defined as more than 1.1 grams per deciliter. High SAG may be further subclassified into high SAG low protein ascites. In this case, low protein is defined as less than 2.5 grams per deciliter, and the causes for such a condition is cirrhosis of the liver, late Budd-Chiari syndrome, or metastasis to the liver. The patient may also have high SAG high protein ascites, and the differential diagnosis of high SAG high protein ascites is heart failure, constrictive pericarditis, early Budd-Chiari syndrome, IVC obstruction, and sinusoidal obstruction syndrome. Patients may also have low SAG ascites, and the differential diagnosis of this includes biliary leak, nephrotic syndrome, pancreatitis, peritoneal carcinomatosis, and tuberculosis. Other aspects of the ascitic fluid analysis include culture, in which case we must inoculate the culture bottles at the bedside. An ascitic fluid with reduced protein confers a higher risk of spontaneous bacterial peritonitis due to low opsonization activity. Cardiac ascites is high SAG, as already discussed, and narrows with diuretic therapy. Also important is lactate dehydrogenase in the ascitic fluid. This is known to be produced by the neutrophils, and it may be higher than in the serum. An amylase level of more than 2000 units per liter may suggest acute pancreatitis. Gram stain is required for the diagnosis of perforation, and cytology may be used to diagnose peritoneal carcinomatosis. Triglyceride levels may be used to diagnose chylous ascites, which is defined as triglyceride level more than 200 milligrams per deciliter. A bilirubin of more than 6 indicates biliary perforation, and carcinoembryonic antigen may be used for malignant ascites. The management of ascites includes treatment of the underlying cause. For example, for cirrhosis, we must consider a salt-restricted diet, diuretics, beta blockers, and the TIPS procedure. Details of the TIPS procedure we have discussed in our video on hepatorenal syndrome. Cardiac ascites may be managed with treatment of the underlying cause and use of diuretics, adequate glycemic and blood sugar control, and angiography or angioplasty if indicated. Nephrotic syndrome may be managed with renal biopsy in the adults, followed by a definitive diagnosis. We may use steroids and immunosuppressive therapy depending upon the biopsy report. In patients with Budd-Chiari syndrome, we must do a Doppler of the hepatic veins to confirm the diagnosis. We must consider anticoagulation with low molecular weight heparin. We must look for a prothrombotic state as well as for a myeloproliferative disorder. Management of infections in ascitic fluid consists of spontaneous bacterial peritonitis, which is managed with cefotaxime 2 grams TDS for 5 days or based on culture reports. Monobacterial non-neutrocytic bactericitis is also treated for 5 days based on the culture report. Culture negative neutrocytic ascites or CNNA, secondary bacterial peritonitis, and polymicrobial bactericitis are all initially managed with cefotaxime 2 gram TDS for 5 days, followed by definitive therapy if culture report differs. That's it for our presentation on ascites. Thanks for watching, and we will see you in the next video.